topic for presentation is Introduction to Epidemiological Concept in VBDs. Previously already regarding what is the epidemiology, basic concept of epidemiology has been discussed by my previous presentator, and now we will discuss about, as we all are working in the system of VBD, vector-borne diseases. We need to know something about epidemiological concept on VBD. We all are working in that. We know most of the aspects of epidemiology of vector-borne diseases. So to start with, again, I am going for that definition. Epidemiology is the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to the prevention and control of health events. It is by John M. Last in 1988. The definition was made. What do you mean by epidemiology? EPE means on or upon, demos means people, and logos means the study of. Study on or upon people about various determinants that is related to health or any health related event. It's called epidemiology. And in epidemiology, what is important, whenever a disease occurs, three things are required to be completed. The triangle need to be completed. At one point of triangle, there is environment, one host is required, and the causative agent makes the triangle complete. So in this way, epidemiological triad is complete. The conducive environment should be there for happening of a disease process, the pathogenesis of a disease process, and host may be zoonotic, maybe human may be a host, and different parasite, viruses, bacteria, they may act as agent. And if you go for vector-borne disease concept, here also vertebrate host because of susceptibility and accessibility. Arthropod vectors are there. It depends upon how the cycle will move. It depends upon age of the population group, evidence of the arthropod vector density, that is, and what activity we are doing daily. And environmental factors like temperature, rain, relative humidity, all acts upon. And with the pathogen and vertebrate host and the vector, the cycle completes in vector-borne disease prospect. And what are the vectors? If we think that vectors are living organisms that can transmit infectious diseases between humans or from animals to humans. And vectors can transmit diseases among different living beings like mice, monkeys, dogs, birds, etc. and humans. What are vector-borne diseases? Vector-borne diseases are considered as the most serious diseases. The seriousness of vectors because of their ability to transmit the disease at a large scale in shorter period of time than any other infectious disease. They are diseases caused by disease vectors. I will go to disease vectors in the next slide. And often it is found in tropical regions where insects prevail and access to drinking water and sanitation measure is not safe. In these conditions, prevalence of vector-borne diseases are more. So next will be disease vectors. In our setup or any setup, the common vectors that can transmit infectious diseases to human are, if we think of vector, mosquito as a vector, then we know malaria, dengue, viral hemorrhagic, chikungunya, LF, Japanese encephalitis, yellow fever, housefly, typhoid, diarrheal diseases, cholera, poliomyelitis, conjunctivitis. If in case of Laos, it is epidemic typhus or relapsing fever. Swine fly causes Kala-Azar. It is vector for Kala-Azar, and heart tick, vector for tick typhus, viral encephalitis, viral hemorrhagic fever. Each mite is the vector for scabies, and CC fly is the vector for sleeping sickness. If we think of mosquito as in out of 6 vector-borne diseases that we are dealing with, 5 are vectoring mosquito and in 1 sandfly, that constitute the most important vector from all vectors that transmit disease to humans. They are found all over the world. The 4 important groups of mosquito which are related to disease transmission are, as we all know, Anopheles, Culex, Aedes, and Mansonia. So prevalent vector-borne diseases are Anopheles, suppose we'll have female Anopheles, malaria. Aedes, if you take dengue, chikungunya, yellow fever. Culex, filariasis, Japanese encephalitis, sandflies, leishmaniasis. And nowadays, we had been trained in the past regarding Crimean Congo hemorrhagic fever and scrub typhus and any other diseases. We are being trained, and a separate reporting system will be there. It is now under ADDC, and we all are working upon that RDSP, disease control, and NBBDCP in your future may work on that. And please, as a vector can cause plague. So let us start with our program part in which we are dealing with malaria. Epidemiology of malaria. Malaria is a protozoal disease caused by infection with parasites of genus Plasmodium and transmitted to men by certain species of infected female Anopheline mosquito. We all know the clinical features of malaria vary from mild to severe and complicated according to the species of parasite present, immunological status of the patient, and intensity of infection and presence of comorbid condition that is called concomitant conditions, diabetes or malnutrition, anemia. All these are concomitant conditions that may exacerbate the severity of the malaria. As you all know, we can see in this slide, first infected mosquito, first infected person, liver gets infected, red blood cells get infected, then again taken by mosquito, it becomes second infected mosquito, then it infects another person who is not ill till that time, now gets infected by another mosquito. So as far as we know, in Odisha context, malaria vectors or principal vectors are 6: Anopheles pilopecis, Anopheles pubiatilis, minimus, Anopheles philippiensis, dirus, and in urban area Anopheles stephensi. Secondary vectors are Anopheles annularis, Varuna, and Sondicus. So this is the cycle in which the whole life cycle of malaria parasite goes like this, as we all are aware of. Sporozoid enters the body, human body, then the whole liver cell goes to bloodstream, liver cell, RBC, then gametocyte, again goes to mosquito, then all the cycle, oocyst to kinate, all this goes on. Then next is reservoir of infection. About this, a person who harbors the sexual form of, that is gametocyte, is called as reservoir of infection in malaria. A patient can be a carrier of several plasmodial species at the same time. Children are more likely to be carriers than adults. Criteria: the person must harbor both the sexes of the gametocyte in the blood, both micro and macro gametocyte. The gametocyte must be mature. Gametocytes must be viable, and they should be in sufficient density to infect mosquitoes. At least 12 gametocytes per cubic millimeter of blood required. This is the criteria to become a reservoir of infection. The period of communicability is, it is communicable as long as mature viable gametocytes exist in the circulating blood in sufficient density to infect vector mosquito. In vivax infections, gametocytes appear in blood 4 to 5 days after appearance of asexual parasites. In falciparum infection, do not appear until 10 to 12 days after the first appearance of asexual parasites. Gametocytes most numerous during early stages of infection. That means density may exceed 1000 per cubic millimeter of blood. In peripheral blood, it occurs in waves. Relapse in case of vivax and oval malaria, usually more than 3 years relapse has been seen after the patient's first attack. And recurrence of falciparum malaria disappear within 1 to 2 years. And Plasmodium malariae has a tendency to cause prolonged low-level asymptomatic parasitemia. So this is an important in the context of where we are finding asymptomatic parasitemia also. Host vectors, as you all know, all ages are liable to get in malaria disease, but some neonatal cases get some immunity. Sex, as females are more covered, and so chances of getting malaria is less than males, and pregnancy makes more vulnerability for malaria. And those countries who are socioeconomically more developed have less number of, it has been observed mostly that they have less number of malaria cases. Housing as a criteria, ill-lighted and ill-ventilated houses, they are suitable building sites for suitable sites for mosquito residence. Population mobility becomes an important part, one place to another. So immune person, semi-immune person get the infection if population mobility will be more or migration will be more. Occupation, agriculture exposes more towards the vector, and so this occupation allow malaria in the persons who are involved in agriculture practice. Human habits like sleeping outdoor without any personal protection makes more vulnerable. And immunity is a factor. If immunity is less, then chances of getting malaria infection is more. Where chronically malaria infection persists for several years. In those areas, people used to get some sort of immunity. Environmental factor, as you all know, season is an important environmental factor. We can see in the Odisha trend also in the month of June, July, August, we are getting most of monsoon is the most where vector density increases, transmission chances increases, and we have already observed. So there were 2 peaks earlier, now we are getting only 1 peak during the month of July and August. Temperature, optimum temperature for development of the malaria parasite in insect vector is 20 to 30 degrees centigrade, and humidity, rainfall, altitude or high altitude, these also affects survival and of this vector, and rainfall also has a role to play. And man-made malaria, the trenches, ditches, and small potholes that is created, that becomes a breeding place for those Anopheles And now we can see in Odisha these two. These are Anopheles culcipacis, Anopheles fluviatilis. Earlier you all have seen this slide, and here we can know that on Anopheles culcipacis population peak in monsoon and post-monsoon months. 5 species complex A, B, C, D, E, except B, all are vectors. And in here, Anopheles fluviatilis distributed in hilly and foothill regions. During post-monsoon season, it peaks. And 4 species complex are S, T, U, B. And S is predominantly anthropophagic and vector. And flight range of pulsiphasis is about 1 to 3 kilometers. Bites throughout night with peak from 7 to 4. And fluviatilis has less flight range. Now come to dengue. Dengue fever is a self-limiting disease that is caused by dengue virus, arbovirus. Agent factor, we are now in Odisha also, we are seeing the number of dengue cases are more in comparison to previous year. So little bit of elaboration will be there. Agent factor, it is flavivirus, it is a viral disease, we all know. 4 serotypes are there. Then V1, then V2, then V3, then 4, then V4. And infection with one serotype confers lifelong immunity to that virus serotype. The first infection probably sensitizes the patient. The second infection with different serotype appears to produce immunological catastrophe. So when that person gets second infection, chances of hemorrhagic or shock syndrome like features to come as a complication becomes more. The vectors are Aedes aegypti, Aedes albopictus. Both carry high bacterial competency for dengue virus. Aegypti is highly domesticated, strongly anthropophilic, and it is a nervous feeder. It bites more than one host to complete one blood meal, and it is discordant species. That means it needs more than one feed for completion of gonotropic cycle. Albopictus, it is an aggressive feeder and concordant species. That means it completes its blood meal in one go on one person. Does not require a second blood meal for the completion of the gonotropic cycle. How it transmits? On uninfected mosquito. Mosquito feeds on human infected with dengue virus. Then after extending incubation period, infected mosquito feeds on uninfected human. So whenever there will be clustering of cases, we usually take one dengue case as an outbreak when for some period of time there is no case in the particular area, but we have seen clustering of cases. Mostly what our entomological team tells that it is Aedes albopictus more prevalent in our state, though Aedes aegypti is also there. Aedes become infective by feeding on a patient. How it transmits on a patient from the day before onset to the 5th day. That is viremia stage. Extending incubation period 8 to 10 days. Once infective remains so for life. The genital tract of mosquito gets infected and transovarian transmission of dengue virus occurs when virus enters fully developed eggs at the time of oviposition. Because of that, for 1 year also we may get the eggs to be deposited there and chances of transmission will be there for a longer period of time. Environmental factors, rainfall and water storage increases the population of Aedes aegypti. Because of rainfall and water storage problems, so the Aedes aegypti population fluctuates. Temperature humidity affects its survival of Aedes is best between 16 to 30 degrees centigrade and with relative humidity 60 to 80%. It breeds in a container. It is because of that only it is called container breeder in and around houses, peri-domestic area. With 2 degree increase in temperature, you compare with previous year and you will observe this year that why we are getting more number of cases because of vector density also and due to humidity and temperature rise than previous year, that extending incubation period of dengue shortened and more infected mosquitoes available for longer duration of time. So the period which we are observing in our previous year, a good length of time, extended period of time, we are getting the infection, 2 to 3 months almost. Continuously, we are seeing number of cases rising down, coming again, slow, it falls, and again there is there are some cases in patches. If surveillance and adequate vector control measures, source reduction measures will be taken, then that can be dealt with properly. But the duration, what I observed this time, is due to humidity and temperature, right? Mosquito bite more frequently due to dehydration if temperature rises and increases main mosquito count. This is also an important aspect. High risk patient for infants and elderly, obesity, pregnancy, peptic ulcer disease, hemolytic disease, CHD, chronic diseases like diabetes mellitus, hypertension, patients on steroid and NSAIDs, they are high risk patient for dengue. They usually go to complication. Aedes albopictus breeding site, we all know where it resides. The breeding sites, we all now this season we have already observed that tree holes, rock pools, cocoa pots, vehicle tires, coconut husk, bamboo stumps, sources under plant pots. In different districts also we have observed many variety of breeding places. Wherever you will go, the tires are common, that coconut shells are common, but where bamboo stumps are more, they become. We have found it here also, along while visiting with entomological team, many places. This is the common Aedes breeding places, what we have seen. Factors why epidemicity of dengue occurs, that depends upon the strain of the virus, magnitude and duration of viremia in humans, the density, behavior and vectorial capacity of vector population. Now we all know that vector density is more during this time due to lockdown, shutdown, early lockdown, shutdown, then migration, people started migrating, all parks and establishment and everything closed, offices were not taken, office premises, establishment premises, institution premises were not taken care of as early, and now we have seen the outbreak-like situation in most places. Susceptibility of the human population, vulnerability of the human population, introduction to a receptive community. When in area no cases is there, suppose due to migration somebody come, it depends upon how receptive that community is to the dengue virus, whether any immunity is there or not, whether one dengue 1 or one serotype previously occurred or any second immunity to any other serotype is there in prevalent in the community or not. Now we'll go to lymphatic filariasis. The epidemiological determinants of lymphatic filariasis is agent factor. It will take 8 species of filarial parasites specific to men. Commonly we know Wucheria bancrofti, Brugia malai, Brugia timuri causes lymphatic filariasis. And periodicity, microfilaria of Wucheria bancrofti and B malai in India, it is usually nocturnal periodicity. It appears in large number at night and retreat from bloodstream during the day. The biological adaptation to the nocturnal biting habits of the vector is the main cause of this nocturnal periodicity, and maximum density from 10 p.m. to 2 a.m. If sleeping habit of host altered, suppose some person usually sleeps at night and now the entire community or in that area will sleep in daytime and they will awake at night time, gradually the reversal of periodicity can be observed in that area. Reservoir of infection, humans. Source of infection, a person with circulating MF in peripheral blood. Minimum level of MF permits infection of mosquito not known. But a man with 1 microfilaria per 40 cubic millimeter of blood infective to 2.6% of mosquitoes that are fed on him. When mosquitoes are fed on carriers having 80 or more microfilaria per 20 cubic millimeter of blood, heavily infected mosquito did not survive when a number of out of those proportion reach to maturity. They usually do not survive. Host factors, men, as we all know, natural host, age, all ages are vulnerable, sex, usually male. Migration also affects in lymphatic filariasis, and immunity does after several years of infection, some community gets immunity for that lymphatic filariasis. Social factors like today's what lifestyle we are dealing with, urbanization, industrialization, migration of people, illiteracy, poverty, all are host factor that increases chances of lymphatic filariasis. Environmental factors are climate influences breeding of mosquitoes, its longevity. Usual temperature in which that favors the vector is 22 to 38 degrees centigrade with relative humidity of 70%. Drainage, as we all know, they live usually polluted water. They like polluted water, bed drainage. Polluted water are major vector breeding Culex mosquito. Town planning is an important factor. Because of that only urban area, a good town planning is important. If there will be inadequate sewage disposal, then we may get more number of vector density of Culex will increase in there. Common breeding place, cesspool, socket pits, ill-maintained drains, septic tanks, open ditches, etc., etc. And we can see Culex fasciatus breeding sites, dirty water in block drains, cesspits. These are common breeding sites. This is the transmission. We can see career bankruptcy, human stage, mosquito stage. We all have seen during MDA, we have discussed. And now we are going for community tasks in 8 districts. And hope in this coming days, 1 month and 1.5 months, 2 entomological teams are there. One is working at Bodh and one is working Jajpur. And we have already requested government for that approval, and they are giving clearance one by one. So this time, whatever logistic we have, mostly we will cover 7 out of 8. We will try to cover 8 also. Epidemiology of JEE. Next, Japanese encephalitis, as we all know, we have discussed a lot, is a mosquito-borne encephalitis caused by group B arbovirus, which is flavivirus. So except in 2016-17 year, we have not seen major outbreaks in the state of Odisha due to Japanese encephalitis. But in patches where vaccination is also going on, still we are getting cases, 1 or 2, 3 cases. That is also a concern for us. Out of 30 districts, in 24 districts, we do have vaccination program that is going on. And we have already written to government for next 6 districts where vaccination program must start. And if you can get approval in all 30 districts, we will be doing that routine camp mode that is followed by routine immunization. Transmitted by Culex mosquitoes, and it is a zoonotic disease. It infects mainly animals or incidentally men. Following an infectious mosquito bite, the initial viral replication occurs in local and regional lymph nodes. Viral invasion of the CNS, central nervous system, is probably via blood, and major outbreaks of JE usually occurs every 2 to 15 years. There is a huge range. This is the JE transmission cycle. You can see Adrid bird, you can see pig. They are pig is the amplifier, and human, you can see the dead end host. Zoonotic disease, but that means only horse as an animal, domestic animal, has been seen with some symptoms of encephalitis due to J virus, but other animals have not shown any sign and symptom. This transmission of Titanorhynchus, Vishnoi, human with the dead end host, transovarial transmission also occurs. The birds, pond herons, adrid birds are maintenance source, and pigs, small pigs, are amplifying hosts. You can see epidemiological feature. You will see the Japanese encephalitis virus infects several extra human hosts. Example, animals and birds. The basic cycle of transmission are pig, mosquito, pig. The adrid bird, mosquito, adrid bird. And the disease transmitted to man by bite of infected mosquito, incidental. Man is incidental dead end host. Man-to-man transmission not recorded. Animal host, pig, that acts as an amplifier. Infected pigs do not manifest any overt symptoms of illness, but it circulates the virus so that mosquitoes get infected and can transmit virus to men. Cattle and buffaloes are mosquito attractants. They act as mosquito attractant. Horse, only domestic animal known to show signs of encephalitis due to the Japanese encephalitis virus. And birds like pond herons, cattle egrets, poultry, some poultry bird and ducks are the reservoir, and that factors that favors outbreak of Japanese encephalitis is mostly increase in susceptible population. That means with vaccination, the number has gradually decreased, and because of that only we are trying a lot for getting vaccination in rest of the 6 districts. If approved, it will be done. So vaccination decreases the susceptible population load in the community. High density of Culex mosquito due to bad drainage and whatever we have studied. So that increases, that favors outbreak chances. Presence of amplifying hosts such as pig, water birds, that also wherever pigs are available, there is chance that the virus will be there, agent will be there, amplification will be there, and community that is residing or rearing pigs gets vulnerable for Japanese encephalitis. And we all know paddy cultivation. This is along with water birds, paddy cultivation are more, wherever paddy cultivation will be there, water birds will come, and chances of getting human infection, because we will be, most of our population will be engaged in agriculture, so chances of getting infection will be more. And these are the 4 favorable conditions which increases chances of outbreak. This is regarding vector-borne diseases, different epidemiological aspect, different determinants, risk factors, and how we can getting knowledge regarding all the distribution and disease determinants of the disease or VBD, vector-borne diseases in the state. Kalajari is not prevalent in our state. Sunfly is a separate component, but we are more also vigilant because our neighboring states are having cases of Kalajari. So nil reporting is going on. So we need to remain vigilant. And again, in this forum, I request that all vector-borne diseases should be dealt meticulously, knowing all epidemiological aspects and categorizing which one of the area is your priority area, basing upon climatic changes, vector density, and prevention and control measures available with you. Thank you.